Hello and welcome back to another episode of Coronacast. I said things are changing quickly, and it seems like every day they are. We just surpassed China in the number of confirmed cases. I shall say confirmed cases because we have no idea what's going on over there in China. But thank you so much again for tuning in. And, like I said, I'm going to try to have as many people on from as many different industries as possible. So we've already had Alex Mueller on to talk about finance and the economy. And today we're getting on my good friend Nathan Dollinger, who is in more of the healthcare data and administration side. So I'm excited to talk to him and just kind of see how data companies are and hospital administration is preparing themselves for the coronavirus and kind of the peak that is still to come. So thank you so much for joining us, Nathan.
Yeah, Josh, thanks so much for having me. And, before we started recording, we were talking about this, bringing back a lot of old memories of when we were doing podcasts and stuff back in college together. Now, years later, here we are again, chatting. So excited to be here, and it is different times, to say the least.
Exactly. I know it was, back in at SLU, it just seemed so simple and so easy, and now, a global pandemic brings us back together, but some positives of it, I guess. So, Nathan, real quick before we hop into anything else, you are currently in San Francisco, which is one of the harder hit cities right now. So, if you wouldn't mind just going into a little bit about what the government has put in place, whether it's a stay at home or shelter in place, whatever order that is, and then kind of what it's actually like out on the ground.
Yeah, of course. So San Francisco and the Bay Area was actually one of the first locations really to start the shelter in place and stay at home rules in the United States, because the Princess Cruise, which was trying to dock in San Francisco. That was like one of the hot spots initially, kind of during those February, March days when the outbreak really started in the United States. So we were one of the first groups, and I remember I was on a work trip and we got a message from our boss pretty much saying like, hey, everybody work from home, don't come to the office, things like that. And then slowly, the Bay Areas, we were locked down starting in about middle of March, early March. And then the statewide lockdown. So there's pretty much no restaurants are open. Everything is takeout. It's only essential businesses that are open, which are grocery stores, marijuana dispensaries are still open, the hospitals and things like that. Most places you can go in and get carry out, but you can't sit anywhere. Mm-hmm. Our office building, for example, they're like, we're only going to open the office for essential businesses. So I am in my office today because for this podcast, I want to have my appropriate headset for good audio and everything, but really my office pretty much been locked down and everything since the last 3 weeks.
So are you still going to work then and working, 9 to 5 days? Or are you working from home completely?
So we're all working remote. And it's pretty much, coming downtown, it is the amount of traffic, like for example, public transit, they're at 8% of their normal capacity of pedestrians using them daily. So it is a ghost town down here. Most things aren't open. Most restaurants aren't open because down for San Francisco, for those who aren't familiar, there's the place called the Financial District, the larger business area, and not a lot of people live there. They live in the surrounding communities. So down, if you come to the office on a day, it's a ghost town. There's nobody here. It's very easy to social distance because there's nobody down here. So you can come and be by yourself, but it's a strange experience to say the least.
Everything has felt so surreal for the last couple of weeks. And then last thing I'll ask about California in particular, when is your stay at home or shelter in place, whatever they're calling it, in effect till? Like in Denver, we just got one till April 10th, which I would assume will be extended, but it's too early to tell. What about California or San Francisco?
Yeah, great question. So I was actually they put a date on it initially, which was really it was supposed to be April 7th, I believe. But I looked at the rule today because I was looking at going home for the Easter holiday and stuff like that, and it just says indefinitely. So I do not think it will actually end on that, just based on kind of the trends and everything. It'll probably go to the end of April, I think, here in San Francisco.
That thing that Trump came out and said this week of trying to have the economy and everybody restarted back by Easter, it seems a little bit, even at the time he said it seemed ridiculous, but it just seems more and more ridiculous each day. So
yeah, I can see certain areas, certain areas of the United States opening up, rural areas being more free. but like San Francisco will do whatever LA does.
Hmm.
LA is not New York because it's more of a sprawling community. San Francisco
Yeah.
is a little bit closer to New York. It's a little bit more dense, but I don't think California will be kind of the last to react. If anything, we'll start weaning back on.
Hmm.
So I don't think our office will start working from the office until the end of April.
Yeah, or at earliest probably at this point. So, I do want to hop into this topic. So before we get there, thank you for talking about San Francisco. But will you go into a little bit of your background, some of your schooling, your degrees, and then what you're doing for Luma Health and what Luma Health is for those who don't know?
Yeah. So I've been interested in healthcare ever since like I entered college. And, starting sophomore year, I worked as an EMT in St. Louis when Josh and I were there at school together. So I worked as an EMT, and that's what really got me involved in kind of like the care side and the emergency side. So looking at what is going on today with this epidemic, I can relate a lot to the experience and what people are going through. So I find it very interesting to watch. Following that in school, I was focused on health information management, was kind of the information administrative side of the healthcare system, as well as I got my master's in health data science. So talking about, during the pandemic, everybody becomes a statistician. I find it so interesting. And a lot of the only thing we really know is that we don't know a lot. But people like to make broad assumptions based on the current data. And I would love to lend some opinions. We'll probably hop in that later. But then in St. Louis, when I was getting my master's, I worked for a company called the St. Louis Area Business Health Coalition, which taught me a lot about the inner workings and relationships between patients and businesses and how they interact with insurance companies as well as the large healthcare organizations. It was such an interesting perspective. And then following that, I decided to move out to San Francisco, and I found a job working at Luma Health. Luma Health is we are a digital healthcare company. We have something called like a total patient engagement platform where we work with outpatient practices all across the country, groups that are primary care practices all the way up to specialty practices like such as dermatology or orthopedic groups to help better engage their patients, and through technology solutions such as online scheduling, text message reminders, automated scheduling solutions. And for example, right now during the outbreak of coronavirus, we've really been expanding our telehealth platform. And that is just a thing that is blowing up across the country. Telehealth is there was a small percentage of practices in healthcare, whether it be nurses or doctors using telemedicine. Following this year in coronavirus, I think that will probably quadruple in those amount of providers using telemedicine moving forward.
Yeah, and I assume obviously not many people are actually going to be going to a general practitioner appointment right now or anything like that. Obviously, most of those, dentistry, anything like that is kind of on hold for the time being. So telehealth is really one of the only ways you can talk to a doctor and not go into the office, especially if they don't want you in there. Now, real quick with Luma Health, obviously you talked about working with some private practices or kind of more specialized. Are you working with emergency rooms and ICUs at all, or like bigger hospitals, or is it usually on a smaller scale?
Yeah, so interesting. So our solution doesn't work exactly with emergency rooms because it's more practices who have what you can consider like a scheduled visit. So mostly outpatient practices, but as coronavirus started becoming a thing, large academic medical centers across the country started reaching out to us and like, hey, we need to start reaching out to hundreds of thousands of patients immediately. We need access to your platform so that we can message them, educate them, prepare them for this outbreak, because they didn't have the tools. They didn't have the ability, when it comes to medicine, you can't use just like an email listserv and just email your patients. It has to be in a secure HIPAA compliant environment in order to reach out to these patients. So literally we've helped practices all across the country send out millions and millions of messages to all their patients to educate them and prepare them and educate them on resources for testing centers and things like that all across the country. So it's very, very interesting and how quickly things are changing and the demands in the healthcare environment to better educate their patients.
And you talk about those demands that Luma Health has recently had. And I continue talking about March 11th as kind of the date that coronavirus came to America. That was the date that, the NBA season suspended, the March Madness was canceled. What were your guys from Luma Health standpoint? When did you kind of notice that, like, oh shit, this thing is going to hit America? Was that day, or was that prior to that? When did you kind of see an uptick in being like, okay, this is actually going to really be something from a company standpoint?
Yeah, so about a week, maybe 2 weeks before then, we first saw, um, you know, March 11th was the big day when all the sports got canceled, and that's what really like resonated with everybody. But before then, a lot of larger conferences were getting canceled, like some big names that most people
South by
probably
Southwest.
exact South by Southwest and things like that. Well, in the healthcare space, there's something called HIMSS, which is a big one that is people from all across the world come to. Well, that one was canceled, and that's what got everybody their ears perked up. A lot of people from our company were ready to go. Then other conferences of ours started getting moved around. We're like, okay, and myself, so at Luma, was a customer success manager. Now I'm more of our strategy and operations for customer success here at Luma. But like we had on-sites planned with some of our practices across the country, and we were flying out there, and then all of a sudden all those started canceling. Like, because this whole concept of going out to be on site, even though it's so beneficial, it's like, hold on, we don't want to spread the corona around. And then the first thing we noticed was all our practices started reaching out to us like, we need to change all of our messaging and education and everything. So like we work with thousands and thousands of providers all across the country, and all of a sudden we had to totally shift our offering. And then when people started demanding a telehealth solution, that is when we knew. So like we were thinking about developing one, but then we didn't have one ready. Right as people started demanding it, and we flipped one on in about 6 days. And now by the end of this week, we'll probably have a few hundred providers using it every day.
Wow. And was that telehealth option, was that built in-house? Do you have coders in-house, or was that outsourced to another company?
Yeah. So originally we were going to use another platform that we kind of partnered with, but then we were just like, the workflow wasn't good. We need to make it a seamless experience for our providers, for our staff members, for all the administrators, and for the patients. So we built one in-house, and now it's ready to rock and roll. I'm kind of helping lead the build out of that. I mean, our engineers all in-house, they're incredible what they built, because this is the way of the future. And I can almost guarantee that most practices are going to have on hand some sort of telemedicine solution to use in the future. And I don't know if you know about the laws, but when they started breaking out, like the government was like, you know what, there's no restrictions. You can use FaceTime, you can use whatever you want for telemedicine. Mm-hmm. Well, so a lot of practices were like, okay, what's easiest? Let's use Zoom, let's use FaceTime, things like that. Well, those laws are going to go away, and you won't be able to keep using those things. You will need something that is HIPAA compliant, that is secure for patients. So a lot of people are moving to solutions like ours because we already have everything in place and have a larger ecosystem of tools that will benefit them long term.
Yeah, and then actually this makes me think of something. My neighbor, who is a clinical psychologist, has been visiting patients or seeing patients via Zoom, and he's been telling me about how difficult of a process that is, because he has to call them on Zoom, then he's got another application where he has to write down the information, then he's got another thing just to keep track of the information he's writing down. Is that all kind of streamlined with the Luma Health services, or is it kind of still like these doctors are still gonna have to do their reporting through another application? And obviously that's a little complicated because each hospital probably has their own system, but how does that kind of work?
Yeah, so the other system typically is either an EHR, electronic health record, or something called an electronic medical record. So like ours is, we integrate with those systems. So we automate all the communication. So like if you have a telemedicine appointment with your provider, we will send you that link automatically, send a notification to the provider. You just got to click it. No really manual process for the providers. You all connect automatically. During that experience, the provider then can document in their EHR with notes and things like that. And then whenever it's concluded, we provide, because one thing is billing. You need to be able to document that this interaction occurred. So using something like Zoom or FaceTime for evidence of that interaction occurring, you have to bring data from multiple sources. But since ours is integrated with the EHR, we can automate that reporting a lot easier for practices. So there's a lot of administrative lift for this, but we help kind of streamline that and make it easier I always think that we make it easier for practices to do what they do best, and that's care for patients.
Yeah, it's interesting how we can kind of see now in a time of crisis with a pandemic that your company, which had been very forward thinking, was obviously now at the moment of like, okay, now we got to start putting stuff in action. and you're really leading the curve in terms of telehealth and being ready, because so many doctors are still probably using Zoom and other things like that, it's interesting to see kind of the expedited innovation that happens during a time of crisis like this.
I mean, Josh, not even understand, like, any company like ours now, before this, we were not really a telemedicine company. But any company that was in our lane of what we were offering, they are all telemedicine companies now. Everybody came up with a solution because practices need it. It's a need, and there's a demand, and people are going to fill it. And you may have heard like the government kind of saying things like, please delay all elective procedures. So what that affects is in the outpatient practices, their revenue just disappears, and a lot of their patients are afraid to come in. So with telemedicine, what that does is, like, if the doctors have to stay home and the patients have to stay home, doctors can serve their patients from their homes. And it's a great way for those vulnerable populations to serve them without, risking them having to leave and come in for an appointment. And that was one thing, is like with our platform, some people are using it where, like, they message their patients like, hey, when you arrive, don't come inside the office. We'll send you a message when your appointment's ready. We don't need everybody waiting in the waiting room together. Just stay in your car. And things like that, where it's like having a solution that can be mobile to help providers be there for their patients. And right now, with this whole idea of, like, if they didn't have a solution that was telehealth or something like that, they're just left out there, unable to provide those services that are needed.
And this is why it's so cool talking to you right now, is because you're kind of seeing, like, the future is now, in the sense that I've continued to talk about, on air and off the air, of, like, I think VR and AR are going to be one of the biggest benefits from this whole situation. And telehealth, it wasn't a huge thing before this, but, it feels like it's going to be here to stay post-pandemic, whenever that is. This isn't something that you just use during a pandemic and then it goes away. So it's interesting how, we're kind of seeing the future of medicine really change right in front of our eyes.
I couldn't agree more with that. And another thing, which I would love to kind of dive deeper into, is right away, so many of the regulations in our healthcare system or in a hospital-based setting were stripped away, because we've realized that providers need to be able to serve their patients in a more expedited manner. And, like, we are seeing things today where, some of our most skilled providers, a lot of our nurses, they're doing things technically that could get their license revoked, or that would be deemed kind of illegal, because they are valuing the life of their patient more than, like, treating exactly within the means of what their accreditation gives them to do. A lot of hospital-based settings do have to receive authorization from a physician to do certain procedures and things like that to patients. But because of the influx of patients and the influx of demand in a lot of our healthcare settings, like, physicians are trusting their nurses are trusting the rest of their team members, and they are acting as one and kind of circumventing a lot of this red tape. And a lot of individuals are asking themselves, like, why is this red tape there to begin with? Is this, like, obviously it is hurting us in this moment. This is a unique moment, so this isn't exactly like regular everyday activities, but are these restrictions and regulations correct? Should we enable nurses? I'm a big proponent, and this is a bias of mine, but I'm a big proponent of, we have some of the most skilled healthcare providers in the world, between our nurses, our nurse practitioners, our physician assistants, and a lot of them aren't delivering care to what they potentially could because of restrictions and safeties put in place, which many of them have good reasons for. But we are seeing today that in times of stress and like a pandemic like this, which is rare. I mean, Josh, you and I may never see something like this again in our lifetime, but it is transforming our perspective on healthcare very quickly.
And that's one of the things that is so interesting about a moment like this, where that may be those thoughts that you've just had and said, maybe something that you have talked about on a smaller scale with, certain individuals. And maybe it's something that has been kind of, one of those unspoken rules of, not unspoken rules, but unspoken thoughts of medicine, where it's kind of like there's all these red tapes that would be helpful to get rid of. And then it's so interesting. You have just such a huge mirror show kind of all of the faults in a system at one time and in such a quick, time period that you have to be able to react quickly. And a lot of those things that maybe people were talking about what necessarily wasn't making any progress towards have now quickly expedited to help transform the industry quickly.
Mm-hmm. And we're seeing that, I mean, just to give tangible examples, like we're seeing that with trying to quickly find a vaccine for the coronavirus. So we're dropping the normal protocol, which could take up to 6 to 7 years to find a vaccine. We're doing things with so a lot of things you hear about these PPEs, like personal protective equipment. So there's like standard rules of like how you interact with patients, go in and out of rooms, and we're like kind of changing those to accommodate other situations. And it's just, I love seeing the flexibility and seeing providers and care teams excel in these situations rather than be hindered.
Yeah, and it'll be interesting to talk to you in a couple months, kind of as we are either, through the pandemic or still learning more about it and just seeing how your opinions on all this have changed. One of the things I did want to talk to you about, and, you aren't maybe quite as experienced as somebody who's working directly in the hospital, but you do have a bit of that background and you are really adjacent to that hospital administration. I just wanted to talk to you about like the healthcare admin side of a hospital. And when you have this influx of patients so quickly and you have this thing that is so novel that nobody's ever seen before, obviously people are talking a lot about the nurses and doctors and the people who are really on the front lines of treating those people. But I think one of the things we're not really talking about is like what impacts this has from a healthcare administration standpoint. So what are some things that you can talk to, especially about like how hospital administration and systems, are dealing with a pandemic like this?
Yeah. So to talk about that, I would love to kind of take a step back to see. So when the coronavirus, COVID-19, whatever people like to call it, when it first started in China, they originally didn't think that it could pass from human to human. So when we track back when the outbreak started in Wuhan, a lot of the transmission actually happened within the healthcare setting. So it was a lot of providers treating patients, and then they didn't show symptoms for a long time, and it actually spread throughout the kind of the healthcare team that were helping patients because they weren't taking proper precautions. Then once they figured out that it does have human-to-human spread, they quickly changed and stopped that. But that is something that is it's a very scary thing. Because that's the thing, all the sick people go to the hospitals, and protecting yourself is very scary. So I working as an EMT for 2.5 years, we would walk in all the time to an infectious patient who had, everything from like TB to MRSA to whatever have you, and taking proper precautions so you yourself won't get sick, and then pass that on to other people and keep spreading that to others. We're being affected by a couple of things right now. You asked about data. Like, we don't have enough information. What happened initially was, at first we didn't think it spread in between humans, and then we saw it did. We saw the spread was about, if the normal flu, you're likely to spread it to about 1.3 people. The estimated amount, if you were infected by coronavirus, was between 2 and 3. So the likelihood of you spreading it to another person is much higher. Then we noted that the likelihood of you succumbing to the illness was much higher. We don't know what that actual number is because, like every day I kind of look at this John Hopkins website thing that has like cases and deaths and stuff like that. Well, I referenced earlier how everybody became a statistician when the coronavirus came out. Everybody's like, look at the data. Like the United States has more cases. Well, the only number that is trustworthy, or maybe trustworthy is not the word, but like free of error, is the death rate, is the number of patients who died.
Yeah.
Because what that means, because for example, the number of patients who are tested positive, that is affected by the number of people being tested, which is affected by the number of tests you have available. So for example, the United States had a suppressed number of diagnoses for a long time because their testing we weren't testing enough patients. So like that number, everybody's like, oh, we surpassed everybody. It's like, we probably surpassed people a long time ago, and there's probably other countries that have even more than us, but like aren't testing. There's also probably a lot of patients who in the United States who had it were never tested and now are okay. So now when we're talking death rates, we're looking at diagnosed patients, number of people who died, and the only people that are diagnosed are those in the United States who go into hospital centers or into CDC approved testing centers. So we don't actually know proper information, and we're not going to know it for years.
Yeah.
We probably won't know it until this time next year, a more accurate estimation of like what actually occurred. So with that, all this unknown, we had to act quickly based on what information we had. We knew it does spread fairly easily. We knew that it was a novel virus that we don't have built up immunity in our society with, unlike the flu. The flu each year infects about 8% of the United States. So if you think if you took that percentage and put it to coronavirus with the estimated death rate, that was about 3 million people potentially would die in the United States, which is very frightening.
Yeah.
So we had to respond quickly and decisively, and there are a few options of how to respond, but we took the approach of stay at home, self isolation, things like that. And now, why is that? Is because we wanted to. You probably heard it, like flatten the curve, because we didn't want to overwhelm our healthcare system. So now this is where it comes to. We're trying to flatten the curve as a society so we don't overwhelm our healthcare system. Well, how does the healthcare system raise the bar of how many people we can serve and how we can do better to make sure that we are serving patients appropriately so we don't have something like what's happening in Italy where they're being overwhelmed. And this is where the healthcare administration and the healthcare teams come into play. What decisions do we make? How can we not have what happened in China originally where we were infecting everybody in the hospital? So for example, it's so when a patient's in the hospital, there's something called a PUI. It's thought of as a patient under investigation. So somebody who may be infected. So pretty much when you have infected patients in a hospital setting, there's a cart outside of their room that has face masks, face shields, full gowns. And anytime you walk into their room, you totally garb up. So like all of our nurse friends and everybody, like they know this way more than I do. But like when I was working as EMT, like we had to do this as well. So you had to garb up, you had to be in all your protective gear. And that was for somebody who was diagnosed with, if they were diagnosed with like MRSA or any infectious disease. Well, here, now it's like so many more people in the hospital are potentially a PUI, a person under investigation, who either is diagnosed with corona or potentially diagnosed with corona. So what health administrators have done in hospital settings, typically, so think of a big academic medical center. You have nurses, physicians, residents, other technicians who need to go in there. When you need to go in a room, instead of having 3 residents come in and check on them and multiple nurses, you have only essential personnel. You need to go in there and treat that patient. If there's a code, so like a code blue is when somebody goes in cardiac arrest. Instead of having the whole team and everybody's running there like like a lifesaver, like a lifeguard running into a pool. Typically, you'll just see people sprinting down the hall. Now you have your necessary physicians, necessary nurses, and necessary personnel who are there administering the code, and then you have other people waiting outside if you need more assistance. So you are limiting the touch points of those people who go in. You are controlling the amount of personal protective equipment that are utilized by the team to conserve those things. So for example, like a lot of people you've probably heard are using 1 mask a day. Typically, anytime you walk into an infected room, you put on garb, and then as you leave, you throw it all off and you throw in the trash.
Wow.
And like, because you throw gloves on when you walk in a room, put a mask on, walk in, and then when you walk out, you toss it. So like gloves and stuff like that, you still use, but for masks, if you're not going into a room of a PUI or a room of somebody who has corona, you can just keep your same mask on because it's more protection for you or from spreading, because really it comes out through droplets. So from you talking and spitting everywhere. So like that's one thing that hospital administrators are doing. Also, we talk about social distancing. Well, when you're working as a team together in a hospital, like you're all in each other's business and everything.
Absolutely.
But there's ways to practice social distancing in hospitals as well, which is like, don't go into the like your rec room or where you have like lunch and things like that and lots of times in the middle of rounds, people might say like a prayer or something, like you don't hold hands,
Mm-hmm.
or you don't kind of interact, keep your distance as a team unless necessary to engage with others.
Yeah.
So reducing the spread inside hospitals to not spread and keep your team healthy is the first course of action that these administrators are taking.
Yeah, and then one thing I did want to say, and maybe this is too broad of a question because obviously each hospital is individual, but there's probably a certain amount that a hospital is, kind of projecting as far as like sick people. So let's say, your hospital is normally 75% of your ICU or emergency room beds are full on any given, week during a regular week. And kind of what is typically a hospital like on the high end of typically what they would prepare for equipment. So if this makes sense, like kind of how much PPE do you want to have in back stock normally does a hospital have? Because obviously like 1-for-1, you're not going to get right. So you always want to have a little bit more. But like typically is there an amount of like PPE that, because obviously that's a huge shortage right now is all the PPE. Is there, is this a problem of just hospitals not planning for this? Or is this a problem of we just literally didn't have enough PPE in the country?
It's a good question that I can't give a perfect answer for because those are I guarantee there's laws and regulations of like each hospital needs to have a minimum amount, and then there's probably you have your own personal stockpiles to accommodate things, but there's just such a drastic influx in such a short period of time that we're slowly trying to pick it up and accommodate for it. But like I said, typically we use them pretty liberally in our care settings because we have an abundance of them. So it's very much like every time you walk in a room that may have an infectious patient, like your new set of gloves, new mask, new garb, everything, and then you just throw it away. And now we're like, okay, well, let's not do that. Like the thing is, we really don't have a shortage as much as like you hear out there. Like there's still like a large amount. We're still supplying the most at risk areas. Like we have a decent amount, but these administrators are putting in place rules that are like, let's be sparing of how we use them just in case. Like really, even though it's been talked about a lot in the news, there hasn't been evidence of places truly running out.
And then one of the things that like some stories you hear from time to time are like hospitals stealing from other or just taking from other departments in their hospitals. So, whether that be an ER nurse taking from, an osteoporosis, section of the hospital, are those departments in the hospital, are they given a specific amount? Because obviously it's not just like this hospital gets 100,000 masks divided however they want. Is each department kind of doing their own ordering from an administration standpoint, or is it a hospital as a whole doing the ordering?
Yeah, good question. So this is where hospital administrators have to make tough choices. And lots of times, like there's a lot of stories out there. And to be honest, like last time hospital administrators make it pretty rough on the care teams and don't always have their care team being, like everybody from a nurse to the physician, don't always have them top of mind. But administrators in this time, someone needs to make a choice and needs to reduce. So areas such as like elective procedures, you use a ton of equipment during those procedures. Instead of doing that, you're going to transition it to another point in the hospital, stop doing those elective procedures, and then you have more resources for those care teams that need them where there is infected patients. And we're seeing more so, even more than that, lots of things that is happening is non-urgent patients or patients who are rehabilitating from some sort of procedure. Like say a patient just had a liver transplant, and maybe they might be in the hospital for like 5 or 6 days after their procedure. Well, they don't actually need to be in that hospital setting. They could be in more of a step down unit, and they are actually being transferred out of those medical facilities, those like larger hospitals, into places maybe for example in New York. Like they're taking non-urgent patients outside of the city into more peripheral medical centers because pretty much you centralize care of these really, really sick patients into the best facilities. And then the patients that don't need to be there, you get them away. So you're not spreading the disease. So you're trying to everybody who's sick needs to be on this side of the hospital with coronavirus or may have coronavirus needs to be over here. Everybody who's not over here. And there's these things. So in hospital rooms, there's this thing called negative pressure, where instead of you're blowing air in to circulate it into the rooms, there's negative pressure in the room. So the room is constantly pulling air out of it, and the fresh air is coming from the hallways.
Oh, okay.
And so you have infectious patients in these negative pressured rooms. So not all rooms in the hospital are like that. So you want to get these infected patients in there. So then the and so you're not pushing all that infected, if you want to call it infectious material, really infectious air into the rest of the hospital. So there's things like that where you need to strategically move people around to accommodate for it.
Interesting. And then how much do you think, how much are patients who are in the hospital not for coronavirus, how much are they being affected by this? Because obviously it probably changes, the amount of nurses and doctors you need to have in the ER and the ICU. And so how does, from a hospital administration standpoint, how do you make sure that every other patient in the hospital that doesn't have corona is also getting the care they need? Because I can see that as a huge issue, especially when you have, coronavirus patients may have 48 hours to live, to be honest, by the time they check in the hospital, versus you might have somebody that's more in kind of maybe not ICU, but needs to be in there for a week or two, but it's not as life-threatening. How do you kind of, from an administration standpoint, how do you determine the best care for all patients?
Yeah.
And I realize that question is one that if you had the answer to, you'd be a billionaire right now, but
no, it's really difficult. And, you really need to account for, I think it's important to note, in the United States right now, today, we are not at that bar limit of capacity. So we're doing okay. We're not running into a bunch of these really drastic situations. What is happening is, so it's very difficult when you have a patient who's near death, and how to handle that bedside. And it's really, really difficult. So there's stories, I heard one today of, so to reduce this spread. So when you have an infectious patient, you're not allowing visitors in. And lots of times if you're trying to get them on a ventilator, well, you actually have to sedate them to put them on a ventilator. So lots of times they're not conscious. So you're making a lot of decisions I guess let me kind of take a step back and explain to people. When you think of, if there's a disaster, say there's an explosion goes off, and there's 100 injured people. You do a triage situation where you have individuals who are most likely, and this is just how it goes, and be pretty blunt, but individuals who are going to die, most likely, and don't have a chance of living. You don't give care to them. You try and make them comfortable, but you move on to those who are most injured but have a likelihood of living. Okay. And then you go to those individuals, those who are injured but don't have a chance of death. You actually put them in line second. And then for those who may be injured but are still abled, you kind of give them a green, put them into a green zone, and you kind of move on, and they're the last to be treated. So you have to make split decisions of, this individual is too sick and is going to die, resources are better put elsewhere.
Yeah.
This person is very sick, has a chance of living, let's treat this person first. So you make these decisions, and those are very quick split decisions.
And who makes the call on that? Is that typically an ER doc, or is that a team of people?
So great question. So this is something that it could take place in an emergency setting where there's paramedics and firemen and police officers on site. But then you take this emergency situation that may take place out in the field and in a hospital, and then you bring it all into a hospital. So this situation is happening a little slower. So it's not as fast moving. So you have a little bit more time to think, but it's still the same principles hold true. As a patient, if a patient's is about to die, you try and give as much care as possible. You don't stop, but at some point you're aware that they don't have any options left. And there's, I was referencing the stories today that I heard about, there was an individual who, I guess, based on the stories of corona, is once you are declining, you decline very, very quickly. And most people die once they are diminishing and are on ventilators. They die pretty soon after if they're going to. Well, since visitors can't come in, there's doctors who get the phone number of their loved ones and call them on a video call, and they just chat on the phone, and say their last words to people, because they can't come in to say anything. And they're yeah. And then, they say, and the doctor I was listening to, she's I've had people apologize for things because they knew that person was going to die, and apologize, say things they've always wanted to say to them.
Yeah.
And situations like that. And that's what people are going through. And what is happening today in a situation like now is those conversations in situations like that are happening more often, where it's, instead of happening, once a day, every other day, a couple times a week, it's happening like 5, 6 times a day.
Wow.
And something to think about overall, the current like death rate in the United States for just all types of death had actually decreased. So we're actually seeing less because of people isolating and things like that. There's actually like less people dying than normal.
Mm-hmm.
But there's a lot of focused area of like types of death,
Yeah.
which is now this corona unexpected illness, which is similar to the flu, which is something we're used to, but it's just such a quick incidence that it's happening a lot, and it's a drain on our resources and a drain on our providers, and it is a very, very emotional, surreal thing, and it's like a time when you really see humanity come out in people. And I give all the love to all of our physicians out there and all of our doctors and nurses. I mean, they're incredible people, and I mean that's why I do what I like. So I've been involved in healthcare. That's why I love it. It's such a crazy thing to be a part of.
And the thing that resonates with me so much is having to have a patient die alone because they have this infection that you can't allow family or other people to come and see them. I think about when my grandfather passed away in 2011, one of the biggest comforts was being there at his bedside when he passed away, because you actually felt like, you had some closure. And for me, at least, I felt like I had some closure on his life. Whereas, if he had been this illness where I have to be, quarantined inside and away from him in potentially another state or another city, and having that pass away without anybody else around him would just be so difficult. So my heart goes out to all those people. And then especially the doctors who, maybe have to have that conversation only a couple times a month, now doing it multiple times a day. It's got to be so difficult for their psyche.
And it's, and that's why, like, you see so much of like the signs of we're out here for you, and what you can do is stay out and stay home for us. Like a lot of nurses and doctors like have those signs and go around social media, but it is fairly true. I mean, being in the healthcare system, I mean, it is only a part of what the healthcare system does, is this emergency rooms, critical care units. It is just a subsect of, the health and wellness and what the entire healthcare system does, but it is the most intimate and the most, it comes to light in these drastic situations and how powerful these people are. It's such a tough thing that it just shouldn't be put lightly, and how important it is to support those individuals at all levels.
Yeah, give all your love to the first responders in this situation, because it's so much has happened so far, and I don't think we're close to the end of it quite yet. And so I do want to try to leave the episode on some positive notes, because we got into some, it is a heavy thing to talk about. So what I've been asking all the guests is just, what are some silver linings that you see? Obviously we talked about kind of the innovation already happening in healthcare with telehealth. So maybe outside of a medical related field, just something for you personally that you've seen as potentially a silver lining, or you think that's something that positive could happen after we get out of this pandemic.
Yeah, no more handshaking. I like the little elbow hellos, the foot shakes now.
Corona bump.
Yeah, exactly, the Corona bump. This is, it's weird to think about it, but as, two guys who are, 24, 25, this is something we probably will never experience again in our life. Between this health epidemic, along with an economic hit, and what this is going to kind of change, there's going to be so much just societal change, perspective change, and that it's, whether good or bad, I find it fascinating. It's a time to learn. On my Instagram profile, there's a quote in there that has, in times of change, learners will, the learners will the ones that are kind of inherit the earth. So those who are open-minded find ways to help. Those who are always open to have their opinions changed and be a person for others. I feel like it's an amazing opportunity for people like us and other individuals out there to really find something they're passionate about and kind of excel on the tail end of this opportunity.
Yeah,
and
absolutely.
I find it like a great opportunity, as much as negative things will happen between now and the next 8 months. This thing will string out for a while, not as drastic as it is now once we get more understanding of it, but it's just a different perspective a lot of people have, and I'm excited for that.
And as I was thinking about this last night, was actually, even if we see a radical amount of good change, I still think we're going to see so much societal change that a lot of people, those people who were kind of just stuck in the way things were and aren't good at adjusting with change or aren't open-minded, even if we go to a way better societal situation, that difficulty of going from one version of reality to another is going to be so difficult for so many people that it's going to be so important to keep your thinking open and keep your learning and knowledge and questioning open. And so, kind of why we're here today. And, I think a lot of good things are coming from it. I mean, we see telehealth is going to advance very quickly as it already has. And, thank you, Nathan, so much for coming on. It's, great to talk to you, especially kind of, you're not necessarily, like I said, in the front lines, but you are a person that's working on rapidly innovating a space that very much needed it. So thank you so much for coming on, and hopefully we'll have you on again soon.
Thank you, Josh. No, it's been great, and look forward to next time.
Absolutely. All right. See you on the other side. Bye.